Fine. So I'll be starting with the presentation on equipment and drugs in neonatology. And so we'll be starting with the basic equipment. So I'll be covering 10 equipments and 10 drugs. Do let me know if I'm going fast or slow. So first question will be, we all have seen this equipment in the NICU. Identify the equipment, name the principle on which it is based, name the situations in which it may not give reliable readings, name the recent technology used in this Massimo machine. So since we see this machine day in and day out, and this is most of us have a favoritism for this machine. So the principle used in the pulse oximeter is Beer-Lambert law. That is, the concentration of a solute in a solvent can be determined by the light absorption. That is, it will calculate the light which goes out by subtracting the DCA, that is, distance traveled by the light, the concentration of solute in a solution, and absorption coefficient of a solution from the light which goes inside the solution. So what happens is that the pulse oximeter that you see daily in your units, it has LED, that is red LED, and an LED light which emits the red light, and an LED light which emits the infrared light. It has a photo sensor on the opposite side. Why red light? Because the deoxygenated hemoglobin or the reduced hemoglobin has a maximum absorption spectrum. That is, the blue line is the reduced hemoglobin. It has the maximum absorption spectrum at the red light, that is 660 nanometer. And the oxygenated hemoglobin has a maximum absorption spectrum at the near infrared range, that is 940 nanometer. So by using this and by using the amount of light which is actually falling onto the photosensor, it will tell you how much amount of oxygenated hemoglobin is there in your blood, and it will convert it into a pulse oximeter reading that you see. So it takes care that only pulsatile changes in the light transmission is measured, because that will give you the value of the arterial pulse. So it may give unreliable readings in patient motion when the baby is moving too much, when there is ambient light in case of phototherapy, when there are low perfusion states, and when there is dyshemoglobinemia. So the Massimo signal extraction technology, that is the SET technology in the Massimo machine, we should understand that the pulsatile is not only the arterial, but venous also has some pulsations. So it identifies the venous signal, it isolates it. Using adaptive filters, it cancels the noise and extracts only the arterial signal. So it gives more accurate reading, and it takes care of the motion artifact and the ambient light. The pulse oximetry, some additional points, that is, what is perfusion index and pleth variability index. So all these machines, you will see something like PI and PVI being shown. So what is it actually? The ratio of the pulsatile blood flow to the non-pulsatile blood flow is the perfusion index. It normally gives a value of 0.02 to 0.20%. So different studies have told its importance. So one of the Indian study I'll be quoting, that it signifies that PI of less than 0.45 signifies under perfusion or low SVC flow states. It is not a well-validated index in neonates that we should understand. It is just under study still. What is pleth variability index? So pleth variability index is the measurement of the relative variability in the pleth of the baby during respiratory cycle. So it will take care of the ventilation and the respiratory cycles. So it is actually the perfusion index, maximum minus minimum divided by maximum into 100. So it's in percentages from 0 to 100%. So pleth variability index, they say that if it is more than equal to 23.5, that same study by Dr. Chandra and unit in Chennai has predicted that it can predict invasive hypotension better if you have a PVI of more than 23.5. So coming to the next equipment, that is the question is, identify the equipment, the principle of this equipment, the site of measurement, the limitation of the equipment, and what are the various zones in the Bhutanese normogram. So the instrument is the transcutaneous bilirubinometer. The principle is reflectance.
Dr. Deena?
Yes.
Yeah, so what we can do is, after you show the picture,
Okay.
you can just wait for 1 minute, let the fellows attempt it. They
Okay,
can also
definitely
get to know like whether
they are able to answer or
wait
not.
for 1
Definitely.
minute and see how many of them can attempt and answer some of the questions.
Okay, definitely. And Dr. Kavita. So the after this question we'll do. So already I have shown the answers for this one. So the principle is reflectance spectroscopy. So what happens is that there are two types of wavelengths which are used. So most of the units they have the JM 103 or 105 machine which uses two wavelengths, that is at 450 nanometer and 550 nanometer. Sometimes you may have a good unit may have also a Billy check which has uses multiple wavelengths, more than 100 wavelengths. But they say that although the Billy check is more accurate, it is less sensitive. The JM105 which we normally have in our unit is more sensitive in detecting. So we need a thing which is more sensitive. So the bilirubin is absorbed at 450 nanometer, but other things are also absorbed like hemoglobin and melanin, but they are absorbed also at 550 nanometer, and hence it will use the calculation to find out the bilirubin which is present in the baby. So the light is reflected onto the forehead or the upper end of the sternum, which is the site of the measurement, and it is reflected back into the machine, and the machine calculates how much of the bilirubin is present in the tissues. Limitation of the equipment is it is unreliable at high bilirubin values, that is more than 15 milligram per deciliter. It can underestimate. So if you have a value of 17, we may actually be having 18, 19, 20. You don't know. It is unreliable after phototherapy as the skin is bleached. And in preterm, the skin barrier is immature. So in preterms, it cannot be reliably used, although studies are coming up examining the validity of this equipment. So what is Bhutanese normogram? Somehow this was the favorite question during our residency because usually you have third, 50th and 95th 97th percentile. But this has different percentiles. That is 40th percentile, 75th percentile and 95th percentile. So this is an R-specific bilirubin normogram using the serum bilirubin values which was constructed by Dr. Bhutani and team. And so it has four zones. These three lines, they divide into four zones. That is the low risk zone, low intermediate risk zone, high intermediate risk zone, and high risk zone. So what you do is that it will tell you that if the pre-discharge bilirubin is this much, it is lying in this zone, the baby should be called after 12 hours or 24 hours or 4 hours if the bilirubin is lying in this zone. So it will tell you when to repeat the serum bilirubin depending upon the gestation age of the baby and plotting the bilirubin value on this normogram. Coming to the third question, can someone tell me what equipment is this? What is its principle and what are its limitations? What is the JCIH 123 rule? Anybody can unmute, answer any of the parts that you know about. So anybody can type in the chat box. What is the equipment?
Okay, so someone has messaged that the chat is disabled. Sarita, is that correct? Because I can do it.
Yes,
Somebody
ma'am.
has also raised
Yeah.
hand.
Okay,
Oh,
I think it's working now.
Is it working only for the panelists? Is it working for the participants also?
It
The
is
chat?
it is working for both. They have started answering.
Okay, fine. Let's see.
You people can either put in chat box or Q&A also.
Yes, so they are right that this is an OAE machine. So I'll wait. I think so. So it is an OAE machine. So what happens is that so the ear probe is deeply inserted into the ear canal. The probe delivers click or a pure tone. That is, click is a loud. It's a broad sound. The transient evoked OAE machine, it uses clicks to see the one which is reflected back from the cochlea. And the distortion product OAE machine, it uses the pure tones, two pure tones at different frequencies. It is more extensive, more specific, but most of the units are having transient evoked OAE machine, which is you can be used bedside. So the microphone measures the OAE generated by the cochlea. The limitations are that it cannot screen the neural hearing loss, not reliable in case of middle ear dysfunction, fluid or debris, and it can give erroneous results because of poor probe placement. So coming to the next part, what is the JCIH 136 rule? So screening should be done by 1 month. So JCIH is the Joint Committee on Infant Hearing, which says that the screening should be done by 1 month, the audiological diagnosis by 3 months of age, and the early intervention, that is whether it is a hearing aid or it is cochlear implant, should be done by 6 months. So now they have improvised. So many of the states, at least outside India, are able to attain the 136 rule. So they have told that if the states have achieved the 136 rule as the benchmark, they should focus on 1, 2, 3. That is by screening by 1 month, audiological diagnosis by 3 months, and early intervention by 6 months. Can anyone name the equipment? What is it used for? So rightly said, it is the flux meter. So the equipment is the flux meter or the irradiance meter. I have got responses in the chat box. It is a spectroradiometer or the billimeter. It measures the irradiance of the phototherapy. So there was a hint in the question itself. So it measures the irradiance of the phototherapy. So an ideal phototherapy unit must have an irradiance of 10 to 30 microwatt per centimeter square per nanometer. So what you do is that you switch it on, you place it at a level where the baby will be lying, you test it in the center as well as the four corners and take an average of the phototherapy of the irradiance that the phototherapy machine is giving. So when your biomedical people come to calibrate the machine, which should be done periodically, they should have a flux meter in their hand. Otherwise, you cannot calibrate a phototherapy machine. So intensive phototherapy is defined as at least 30 microwatt per centimeter square per nanometer irradiance. Can anyone identify the equipment? What is it used for? And describe the principle of its working? Please identify the equipment. More responses I am waiting. What is this equipment? So I think so. There is a confusion in so almost a few of them. So one of them have told FIO to measure an oxygen calibrator. So I would like to call it an oxygen analyzer. Okay. So there is a hint actually. If you can see, it is written 21.0. So it is the oxygen analyzer. So it measures the concentration of oxygen in the inspired air. It uses the galvanic cell to measure the oxygen concentration. So it is actually used to measure calibration. So when you have a blender, if you have to calibrate the blender and you have to see whether actually when you are setting 25%, is the blender giving 25% or is it giving 21%? So you have to see, you have to use an oxygen analyzer for the same. So it measures the concentration of oxygen in the inspired air. It uses a galvanic cell. So what are the components of a galvanic cell? As you can see, there is a permeable membrane from which the oxygen molecules, they diffuse through, react with the cathode. There is an anode. There is a reduction reaction which happens at the cathode and an oxidation reaction at the anode. And this generates an electric current. So this electric current will be displayed as a value depending upon the concentration of the oxygen molecules. So it will give a value in percentage of oxygen that is coming out of the source. So it will give you the oxygen values in terms of percentages, like you saw in the previous one, 21% it was showing. Identify the equipment, everybody knows it. What is it used for? Can anybody tell me the correlation with plasma values? So I want to know whether it measures the plasma or the whole blood glucose, and what is its correlation with the plasma values. What are the principle of it working? So everybody will be knowing the name of the equipment. The next three answers is what I want. So rightly said, it measures the whole blood. Coming to the next question, what is the correlation with the plasma? So very good. Abdul Shabir has told that the plasma values are 15 to 20% more than the whole blood values. And very good. Dr. Reena has told that glucose oxidation method is the principle of working. So rightly said. So it's used for measuring, the glucometer is used for measuring the whole blood glucose. The glucose values in the plasma are 10 to 15% higher than the glucose measurements in the whole blood. So live values should be higher. So I have just take care of the note that in ideal scenarios, it should be higher than the glucometer values. But my personal experience and your personal experience, whenever you send the lab values, always come, it will always come when you send for a hypoglycemic baby, it usually will come lower than the lab values. It is not that it is no, they are not measuring plasma values. It is probably because of the time delay from the time you are taking the sample to the time they are processing. So that delay is the one which is causing a drop in the plasma values. Otherwise, in ideal scenario, if tested, the plasma values should be 10 to 15% higher than the blood glucose measurement. And rightly said, the principle is the glucose oxidase method. So what happens is that the glucose oxidase is present in the strip that you insert. So the glucose which is present in the drop of the blood reacts with the oxygen to form, and it is metabolized by the glucose oxidase which is present in the strip to give rise to hydrogen peroxide. This hydrogen peroxide is detected by the electrode which generates a current proportional to the blood glucose value, and that will be displayed as glucose in milligram per deciliter on the monitor. Coming to the next, identify the spotter. What is the special precaution that needs to be taken while applying this to the baby? Name the disease condition in which it can be used. So this is a pretty simple one. So Optiflow, I would like to, rather than the brand name, which is visible, I think so. Yes, rightly said. Dr. Sunita has told it is an HFNC cannula. So that is what we would like to hear as an answer. That is it's a high flow nasal cannula. What are the special precautions? Can anybody tell? Very good. Dr. Mona has replied that less than 50% of the nails should be covered, because when you are giving HFNC, there is no expiratory limb like CPAP. So you don't have a gap for the air to go. The air has to come out from somewhere. So the nails are the place where from which the air is exhaled air is coming out. So you should leave 50% of the opening. So not more than 50% should be covered. Name the disease conditions in which it can be used. So it can be used in variety of respiratory distress, as mentioned in the chat box, post-extubation. I would like to know where it should not be used compared to CPAP. Can somebody write down where it should not be used should not be preferred over CPAP? Very good. Dr. Manju, Dr. Nikita and Dr. Muhammad have replied that it should not be used as a primary modality from CPAP. So studies have shown that it is inferior to CPAP in case of primary RDS for preterm neonates. So rest remaining any disease conditions that you think of, it can be used, whether it is meconium aspiration, post-extubation, weaning from CPAP, apnea of prematurity, transient tachypnea. Name the equipment. What is it used for? Principle of action. What are the limitations of this equipment? So this not everyone would have seen. I would like to have answers for this. What is this equipment? Very good. So some units still do have, many of the units don't. So it is what is the principle? So the principle will remain the same, the Beer-Lambert law. Okay. So just like so you pass. So now coming to the next slide, that is most of the people have answered correctly. So it is a microbilirubinometer. Microbilirubinometer, because why a microbilirubinometer? It requires only 50 to 70 microliter of blood for the sample. So you need 1 ml, 1.5 ml of blood for estimation of serum bilirubin, but you need only 50 to 70 microliter of blood for estimation of bilirubin in this method. So it is a spectrometric bilirubin analyzer. It is used for serum bilirubin estimation. The principle is the Beer-Lambert law. That is, two wavelengths of light are passed through the serum, which is actually obtained by centrifuging. So you take the sample in the capillary tubing, you seal the sample by dipping it in a sealant, like we used to do it in soap, and then you centrifuge it at 12,000 rotations per minute for 5 to 10 minutes, and then it separates the serum and the PCV. The serum part you insert, ensuring that there is a chamber, there is a hole where you can see that the serum is there. So the serum should be clearly visible through that hole. And you put it inside, you switch on the machine. What happens is that the lights of two wavelength are passed through the serum. The 454 nanometer will be absorbed by bilirubin, carotene, and oxygen hemoglobin, whereas 540 nanometer will be absorbed by only oxyhemoglobin. So the oxyhemoglobin will be taken care of by passing two lights of different wavelength through it. Carotene, thankfully, is less, not there. It's negligible in neonates. You should take care that this method is reliable only in the neonatal period. You cannot use this for carotene, for estimation, bilirubin estimation of a 1.5 months, 2 months child, because the baby will have a higher values of carotene. How does the baby get? Through the breast milk. So mother will be taking vegetables, carrot and everything, and that will go in the breast milk, and the baby will eventually have carotene, which will interfere in the estimation of the bilirubin. So the limitations are, it is not reliable outside the neonatal period. Conjugated fraction cannot be measured, and it is not reliable for neonates receiving lipids because lipemia. So any baby on total parenteral nutrition, you should be wary when you interfere using this method, because lipemia, it increases the turbidity of the serum and plasma, and it will give erroneous values. So many of times this was the actually source of error in many of the neonates we used to do. So this is the principle that the light source is passed through this is a cuvette which will have the serum, the microcentrifuged capillary with the serum. It passes through the serum. The lights are then filtered and detected by the processor, and it is displayed on the monitor as milligram per deciliter, and you can actually take a print and attach on the file of the patient. Identify the equipment. Most of you will be knowing what is it used for, and that also I would like you to answer the next two parts. That is the identify the parts labeled as 3, 4, 5. What are the initial pressures recommended during resuscitation as per the 9th edition of NRP? So everybody knows the equipment. So I would like the answer for the third and the fourth part. So the equipment is TP's resuscitator. Very good. So people have started asking. Dr. Dushna Bano has answered the fourth part. What is the recommended initial pressure? So now it has been changed to 25. The peak inspiratory pressure has been changed to 25. That is 20 to 25 centimeters of water for babies less than 32 weeks. More than 32 weeks, it is 25 to 30 centimeters of water. Very good. The third is let me see, the third I have got answer as one of them. Dr. Karthik has answered pressure relief valve. So it is the maximum pressure relief valve, which is the 3. So it is not the pop-off valve, it is a maximum pressure relief valve. So that actually is working like a pop-off valve, but it is actually maximum pressure relief valve. The terminology is that. Fourth is the manometer. So better answer than pressure monitor will be manometer. And the fifth is the peak inspiratory pressure valve, PIP valve. So the peak inspiratory pressure valve is the come not only to the. So I will let us go through, just briefly go through all the 1 to 7. One is the oxygen tubing, which will give blended air or blended oxygen to the baby through the 3-piece resuscitator. This is the oxygen inlet. 2. 3 is the pressure relief valve, maximum pressure relief valve. 4th is a manometer. 5th is the peak inspiratory pressure valve. 6th is the patient outlet. 7th is the PIP. And so T-piece. 7th is the T-piece with the PEEP valve on the top. T-piece. So we have covered this part. And it is used in the delivery room as well as in the NICU for resuscitation. For if the baby goes into apnea, we prefer in preterms to use T-piece resuscitator. So all the sick preterms, most of the sick preterms, they will have a T-piece resuscitator on their bedside rather than using positive pressure ventilation through this bag. What is this bag? So we know, I would like to know the answers of 2, 3, 4. What are these? And what is the current sequence of ventilation corrective steps? So it's a self-inflating bag, everybody, most of you know. So don't say ambu bag in your exam. You say it is self-inflating bag. 3 is the pop. 3 is not the pop-off valve. It is the manometer. So everybody who has answered 3 as pop-off valve, I would like to correct. 3 is the pressure manometer. It is not present in most of the units as self-inflating bag. This diagram I have taken from the NRP booklet. So everybody should be aware this can be given as a diagram. If the equipment is there and the unit is having a manometer and a PEEP valve, they will definitely give you. So 2 is the PEEP valve. 2 is the PEEP valve. You can actually, we normally cannot give PEEP via self-inflating bag. But if you have a PEEP valve and you set the PEEP via regulating this, by rotating this knob, this is the PEEP valve. And so if a unit for demonstration purpose has this thing, they will definitely keep it for exam. So this is the PWP valve. 3 is the pressure manometer, and 4th is the pop-off valve. The first is the, so there is very good the sequence. So sequence people have answered correctly for the last part. That is, there is no sequence now. So initially it was MR, SO, PA. So that was the initial one. That is, you do mask adjustment, you do repositioning of the neck, you give 5 breaths. If there is no increase in heart, there is no chest rise which is visible, then you go into the SO, that is the suctioning, opening of mouth. Then you again give 5 breaths. Then you see if there is chest rise. If there is no chest rise, then you give P, that is increasing the pressure. If there is still, and give 5 breaths, and then still there is no chest rise, then you give alternative airway. So it was the initial sequence, previous NRP. Now the current NRP states that you do it as you feel. If you feel that the baby will respond better. So if there is any baby with having full of secretions, you don't need to go through MR, SO, PA. So if you have a baby which is full of secretions, you go for suction first. So whatever you think is the problem, you think that the seal is not adequate, you feel that there is a leak which is there in your hand, you can feel the leak, you go in with the mask readjustment first. If you feel that the baby is not opening mouth, is closing the mouth, you go in the opening of mouth first. So any sequence is, so I will again tell the parts. So Dr. Mohammed, I would like you to ask whether you are asking for the parts for the T-piece resuscitator or the, so I will be describing the parts of self-inflating bag. If it is T-piece resuscitator parts you want to tell me, you want me to repeat again, do let me know. So just clearly here the parts. This is the one, is the patient outlet. Okay, so I have not actually described the parts, so I have only described 2, 3, 4. So I'll be describing the entire one in detail. One is the patient outlet. We'll go with 2. 2 is the PEEP valve, PWP valve, and you set the PWP, peak and expiratory pressure, you by rotating this knob. 3 is the pressure manometer. Actually, I only have the side view because my unit also does not have the PEEP valve and the manometer to show you the front view, but I have actually seen it personally. So pressure manometer, it is actually just like a manometer in the T-piece. It is a rotation. You can actually when you press, you can actually see how much PIP and how much PEEP. Just like in T-piece, this manometer will have dial. So you can just rotate. You can see it is a dial shaped thing. Okay, with the needle pointing towards the pressure. This is the pop-off valve, which will release the pressure if the pressure goes beyond 30 to 40 centimeter water. Everybody should be thorough with each and every part of the self-inflating bag. It can be asked in the resuscitation viva. It can be asked in the instrument. So self-inflating bag and the T-piece resuscitation should be thorough. The NRP sequence and the new NRP changes should be thorough with each and every person, because the new NRP changes will be asked whenever they come. They are asked for 1 to 2 years in the exam. Then you have 5, which is the oxygen inlet. This black portion, this area, if there was no reservoir, this would be air inlet, because when you press and you release, the oxygen will go from here, the 5, if it is connected, and if nothing is connected, air will go inside from this black portion. Now already the reservoir has been connected. So this is the air inlet, this is the oxygen inlet, this is the closed reservoir, and this is the oxygen tubing. The 7A is the closed reservoir. You can also have corrugated open reservoir. So I hope it is clear for all. So T-piece half means this kind of bag. So this kind of bag, although it is there, it is a crude method. It is not so accurate actually. And you cannot regulate PIP. So in T-piece resuscitator, somebody has asked me, what is the advantage of T-piece over this bag? Why don't you use this bag? I cannot regulate. I want to give, it is just an estimation. So when I press slowly, 15 will be given. When I press hard, 25 will be given. When I press more hard, up to 40 will be given. But there is no adjustment. You cannot, when you are resuscitating a baby and it is such a complex situation, you cannot just press and keep on looking at the manometer, what is the pressure. You need something which is preset. So T-piece gives you an advantage of giving preset values. And obviously you cannot give free flow oxygen through this, which can be given through the T-piece resuscitator. That is also a difference between them. So the delivery of the PIP is more accurate in case of T-piece resuscitator as compared to the PIP. PEEP still this will give, but PIP delivery will be more accurate, and PEEP also is a bit crude in this. So we have covered this, and next. So we know this is calcium gluconate. What is the dose in case of symptomatic hypocalcemia? So we have to cover drugs, 10 drugs, and the drugs will be covering fast. Will take less time. So 2 ml per kg IV bolus over 10 minutes in 1:1 dilution, and followed by, so somebody has written 8 ml per kg per day, followed by 8 ml per kg per day for 48 hours. Then you check the value. What is the value? If the value has normalized, then you drop to 50%, that is 4 ml per kg per day for another 24 hours. Okay, very good. What is the strength of injection calcium gluconate? Good, 10%. So 10% is the strength. Next, name one other indication. So it can be used in symptomatic hypocalcemia. Very good. Dr. Nikita has written hyperkalemia. Hyperkalemia for cardiac stabilization. People, many other have started answering. Is another indication where calcium gluconate can be given. What precautions will be taken while administering calcium gluconate? So it should be under cardiac monitoring because bradycardia can happen. Anything else other than bradycardia? Somebody wants to answer? Another precaution. Very good, doctor. So one very important precaution which we are very afraid, because this thing you can actually see in the monitor whether bradycardia is happening or not. The IV side, if you are giving IV calcium gluconate, you should make sure that the sisters have put a fresh cannula, or the cannula is working very well by flushing and seeing. If there is any doubt that it may be bulging, advise that a strict instruction to all the sisters never to give calcium gluconate from any of the doubtful cannulas. Okay, because the skin extravasation is very bad. It may go into necrosis, slowing, and the baby and the parents will give you a tough time of your life. Okay, so be very, very when you are giving IV calcium gluconate is what I would say. Next, what is the indication for usage of Alprostadil injection? What is this? First, the name, the content of this injection. What is it used for? What is the concentration? What are the starting and maintenance dose? What is the most common side effect? So very good. I have got the answer. PGE1, that is prostaglandin E1. It is used in duct-dependent lesions to keep the PPG1 open. So I have started getting side effects. So very good. Dr. Manju has answered it. The strength is 500 microgram per ml. Okay. It is actually apnea. It is the most common side effect. That is the one side effect that we should be very wary when we are administering alprostadil injection. So apnea, because if you are transporting a baby of DDPC, or duct dependent pulmonary circulation, or systemic circulation, from your unit to any other cardiac unit, and the baby is on PG1, you should send a resident with the baby who is capable of intubating the baby, because there is a chance that the baby may have apnea during transportation. So apnea. And somebody has also written flushed. So actually there is hyperthermia and bradycardia. So these are actually known side effects of PG1 infection, PG1 infusion. So what is the starting and the maintenance dose? I have not got answers for that. So the starting dose, as everybody can see, it is 0.05, so 50 nanogram. So 50 nanogram is 0.05 to 1.1 microgram per kg per minute. That is the starting dose. And then after you have started, if the baby has stabilized, then you come down. You come down to as low as possible as 0.01 mics per kg per minute. Okay, the usual concentration, somebody had already told, it is 500 microgram per ml. So your unit should be having a correct policy on how to reconstitute, how to administer, what is the dose, what is the maintenance dose. So next is adenosine. What is the use of this drug? What are the usual concentration? What is the dose of administration? What care should be taken? So SVT, so that is supraventricular tachycardia, everybody has told. What is the usual concentration? Still waiting for the answers for the usual concentration. So it is 3 milligram per ml. 3 milligram per ml or 6 milligram per 2 ml. That is, you get a 2 ml vial, that's a 6 milligram per 2 ml. And so very good, the care should be taken is that you should give it via central vein. So we usually put we secure a vein in the elbow, as close to the heart, so that in the elbow we'll be securing the vein, and we'll be placing a three-way. We will give adenosine from one end and we'll give flush from the other end. So you should flush immediately as soon as possible. And so 6 mg per 2 ml. Okay, what care should be taken during the administration? What is the dose of administration? What is the dose of administration? We have got 1 kg, 0.1 mg per kg per dose, followed by bolus. So 0.1 mg per kg per dose, followed by the next dose. What will be the next dose?
Dr. Dina, you got muted.
So the next dose should be 0.2 mg per kg. So it should be 0.1 mg per kg for the first dose, followed by 0.2 mg per kg for the next dose. So maximum 6 mg. So our babies will never reach the 0.6 mg and 12 mg maximum dose. So it is 0.1 mg per kg for first dose, and the second dose should be 0.2 mg per kg. Adrenaline or epinephrine, what is the concentration of this drug? So 1 is to 1000. How much milligram in? So 1 milligram per 1 ml. So I have also got the answer for this. It is 1 is to 1000 or 1 milligram. So 1 is to 1000 means 1 gram in 1000 ml. That is equal to 1 milligram in 1 ml. What is the dose and concentration of medicine? What is to be used in intratracheal? So I have started getting answers. So the correct answer is 1 is to 10,000. That is, you have to take 1 ml and mix it with 9 ml of normal saline. Make it 1 is to 10,000 and then give 1 ml per kg. So what you do is that you dilute it into 10 ml. Then you load it in two different syringes. One is 5 ml syringe and label it that it is to be used for intratracheal. And then you load it in 1 ml syringe and label it in that it should be used for IV, because it is difficult to load and do it during that time of emergency. So you dilute it in a 10 ml, you take it into 5 ml and 1 ml syringe and label them properly. So it is 1 ml per kg for intratracheal. And how much is the IV dose? 1 is to 10,000? 0.2 ml per kg. So Dr. Hima has answered and many of them have answered. It is 0.2 ml per kg for IV. And how frequently can this drug be administered? 3 to 5 minutes. So I have also got the answer for that. 3 to 5 minutes is the frequency with which it can be administered. So I will wait for the answers for which receptor does it act in heart and the blood vessels. So we have got the answers for most of them. The last part I would like to focus. So it will act on beta 1 and beta 2 receptor and alpha 1 receptor in the heart. That is, it will cause chronotropy. That is, it will increase the heart rate as well as the force of contraction. In the vessels, it will act on beta 2 initially. So what happens is that in the initial part, that is, if you are starting at a very low infusion dose, I am not talking about resuscitation. In the infusion dose, if you are starting with 0.05 mics per kg per minute, it will predominantly cause increase in the heart rate without causing vasoconstriction. But if you increase it beyond 0.1 mg per kg, mics per kg per minute, it will, because of the alpha 1 and alpha 2 action, it will also have, with the increase in the force of contraction, it will also have vasoconstriction. So what is the dose? This is dexamethasone. Everybody can read it. What is the dose of antenatal administration of this drug? Very good. So I have got the answer. It is 6 milligram BD intramuscularly 12 hours apart for 4 doses. So 6 into 4, 24 mg. Benefits of antenatal. I would like you to enumerate benefits of antenatal administration of this drug. So we are very fond of dexamethasone as neonatologists. I think so. Besides any other drug, this is our favorite drug because it will help prevent so many complications, and then we don't have to work much for the baby to survive. So it is very good. Mortality, NEC, RDS, IVH, I have got. BPD, although it is decreasing indirectly, we don't say the Cochrane does not provide evidence for decrease in BPD. So BPD we don't say as a direct evidence. We say so so I would be showing the slide. So it is mortality, both neonatal and perinatal mortality. RDS, moderate to severe RDS, as well as need for mechanical ventilation. IVH, infection in the first 48 hours, and necrotizing enterocolitis. So necrotizing NEC is by 50%. So it is the maximum reduction is in the NEC. So I used to remember it with the mnemonic MRI neck. So mortality, the RDS, IVH, and necrotizing enterocolitis. Okay. So coming to the previous, so what is better for antenatal administration in India? Dexamethasone, better, betamethasone? Can anyone tell me? Dexa, because it is feasible, available, heat stable, I would say, heat stable. Very good. So Dr. Nikita has and Dr. Mohammed Faisal have actually told correctly why we are preferring. So I would like to go through those slides for details actually. I would like you to focus on the screen for now, which is better. So please, everybody, please focus on the screen. So the betamethasone that we have, when we are saying betamethasone versus dexamethasone, all the studies have been done with this betamethasone. That is, it is having acetate, which is the long-acting part, and the sodium phosphate, which is the short-acting part. This combination drug is more costlier as compared to dexamethasone sodium phosphate, which is actually available to us. So this is the Dexona dexamethasone sodium phosphate, which is short-acting and is available in India. This long-acting is not, the long-acting one, that is the acetate combination, is not available in India. This combination, when you compare the price of these, there is a 30 times difference in the price. Okay. What is available in India is this betamethasone. It is almost of the same price as the dexamethasone. But the problem is that this is the short acting. We are giving the short acting. If somebody is using betamethasone in their unit, they are giving the short acting one as 12 mg 24 hours apart, which actually we don't know is effective or not, because you are giving the short acting part one like a long acting dose, which is not actually correct. Okay. So this is the cost of both of these is almost same. But whereas when you compare the cost of both of them, this is more heat stable, this is less costlier, and this is freely available. So dexamethasone, and when you compare both of them, there is not much difference between dexamethasone and the betamethasone combination salt. So in terms of efficacy, both will fare good. But in terms of cost, when you see, and the availability and the heat stability, so all those things, dexamethasone wins. That is why the WHO guidelines say dexamethasone is the one which is recommended. So IM doses is less if you are using the combination salt, but that is not available. The action 3, I would like you to say the action 3 trial. So we had action 1, action 2. Action 3 is the one which is done in LMIC, which is actually comparing the short acting salt with the dexamethasone short acting salt. So when these results are available and they are equivocal, then we can say yes, betamethasone sodium phosphate can be used, but we should take care that they are using 2 mg dose 4 times, that is 12 hour apart. They are using short acting as it should be used. That is, they are using 2 mg for 12 hour apart for this trial. And when these results are available, then we will be able to say that okay, it is effective, but that time also we'll have to change the dosing for the betamethasone. So what is DART regimen? Okay, I would like you to answer the next part of the question. What is DART regimen? Anybody? What is DART regimen? I had accidentally shown, but I want the participants to answer. What is DART regimen? For BPD, very good. So it is low dose dexamethasone. That is, you are giving 0.89 mg per kg, 0.89 mg per kg over 10 days. It is spread. Very good. People have answered. They know. Dexamethasone and randomized trial. So this is the trial which gave the DART regimen for prevention of BPD. It should be started between 7 to 14 days, not more than still before 7 days because the complications are higher, not after 14 days because the benefit will be lower. And the DART regimen protocol is that you are giving a total of 0.89 mg per kg over 10 days. I would not, so it is 3 days same dose, 3 days tapering dose, then 2 days, then 2 days. Okay. When do you give? So will I give? When do you give? How do you decide in your unit? So all of them who have answered DART regimen, they obviously are using DART regimen in their unit. I would like you to answer, if a baby is on CPAP with 21% FiO2, will you give DART regimen to the baby on day 7 of life? or he's on ventilator on 21%, for all you know. So will you give dart regimen? So how do you decide on when to give a dart regimen to the baby? So I think so. There will be a difference in the unit policy how they. Very good. So I wanted to look when you're asking a question like this, you need an answer which is in your heart. So Dr. Vipul has answered. It is there can be other scoring which I am not aware of. So it is what I was looking for is the BPD calculator. Okay, so you have NICHD BPD calculator where you enter the gestation, the birth weight of the baby, the oxygen requirement or the ventilatory support at 7 days of life, and then it will give you an answer whether the baby is at risk of BPD or not. So it will give a risk as mild BPD, moderate BPD, severe BPD, and death. How much is the risk for a baby? If your baby's risk of moderate to severe BPD and death is more than equal to 65% or 60% for IOSA, 60 to 65%, then you consider giving dart regimen for that baby. Any baby with a risk less than 60%, I would not give dart regimen because the complications can be there in terms of hyperglycemia, hypertension, bowel perforation. So if the baby's risk is less than 60%, according to that NICHD BPD calculator, I would err on the side of not giving it. Last four. What is the usual concentration of this medicine? Dopamine. And what is the indication? Which type of shock will you use? That is what I'm looking for. 40 mg per ml. Very good. 40 mg per ml. Next, what is the indication? So I have got the answer for the concentration. What is the indication? In what type of shock will you use? Everybody knows we use it in shock. In what type of shock will you use? Will you use it in? So diastolic hypotension. So you will not use generally dopamine is not preferred for cold shock or cardiogenic shock. So you would prefer it for diastolic hypotension, not systolic hypotension. Okay. So you will prefer it for diastolic hypotension when your diastole is lower and a warm shock case. So that is a scenario where you will use dopamine or norepinephrine. The cardiac shock, we will prefer a cardiogenic shock or a systolic dysfunction, we will prefer dobutamine or adrenaline. That is one concept that everybody should be knowing. It may differ between consultant to consultant. So the dose is 40 mg per ml. You have already told. The receptors is that the most common receptor that it will be acting. It will act in beta 1, beta 2, alpha 1, and the dopamine receptors in the kidney cause renal vasodilation. But the most common receptor that it acts is the alpha 1, alpha 2, which will cause vasoconstriction. So dopamine is used in cases with low diastolic BP, that is warm shock. So coming to the next, that is what is the percentage of this injection? Potassium chloride. How much percentage? So I have 8 minutes more. I'll wind up fast. The milliculents, everybody has correctly answered 2 milliculents per ml. What is the percentage? What do you write when you? It's a 15% injection. Okay. And what is the treatment you give in case of accidental injection? So you have ECG changes in accidental injection. So we have already covered this in case of in the calcium. It is calcium gluconate. So you'll give, so they have ECG changes. What are the ECG changes for hyperkalemia? Please enumerate the ECG changes for hyperkalemia. Very good. Tall T waves. Next. So the tall T waves is the first thing. Next, what will you have? Wide QRS. So somebody, Dr. Suneet has also said wide QRS. Dr. Nikita has said flat P. Very good. Prolonged PR interval and prolonged QRS duration. Very good. In the end, everything, severe hyperkalemia, sine wave. So Dr. Hima, Dr. Shyam, they have mentioned that sine wave. So these are the typical ECG changes. That is tall T waves, peak T waves, wide PR interval. The PR interval is increasing. There is wide QRS and there is peaked T waves. There is a loss of P wave. Finally, there is a loss of P wave, and then you have a sinusoidal sine wave pattern or sinusoidal wave pattern in hyperkalemia. Very good. Next, what is the 8? What is the sodium bicarbonate injection? How many milligrams of sodium bicarbonate is present in 1 ml? So it's only 1 ml, 1 milliculents. Next, what are the side effects of its administration? So what are the side effects that you will find? Intraventricular hemorrhage. So all the neonatologists, they avoid because of intraventricular. Any other side effect? So everybody has answered IVH. Any other side effect? Any other side effect? hypernatremia. So extravasation, right? We said extravasation is one of the side effect, and CO2, very good, very good. So Dr. Muhammad has answered, that is CO2. So this bicarb will cause buildup of CO2, and actually can lead to it. The CO2 will cross the blood-brain barrier and actually can cause stupor and coma for the baby. So that is one thing you should be very wary when you give soda bicarb injection. Okay, is the drug, we all know, is it recommended? Cannula? No, it is. Everybody has answered. It is not recommended in resuscitation. Which diluent will you use for reconstitution? So 5% dextrose, sterile water or 5% dextrose. What we want to hear is, we don't want to hear normal saline. That is what I am saying. We don't want to hear normal saline. That is, you don't, because it's already having sodium, we don't want to hear normal saline. It is dextrose, 5% dextrose or water. Okay, so it is the concentration is 8.4%, which is 84 milligrams per ml. 1 milliclose of soda bicarb is present per ml. And side effects are tissue necrosis, IVH, CO2, CSF acidosis, mental stupor, coma, and it is not recommended for resuscitation. So all of you have answered most of the question. In the last 2 slides, name 2 conditions in which the phenobarb is used. So we all know, we all have used it. What is the phenobarbital? Seizures first. Second, for priming the baby for HIDA scan. So I would say, rather than hyperbilirubinemia, obviously we were using justice. So for priming the baby before the HIDA scan, and click the nausea, rightly said. Suspicion, obviously diagnosis will take time. You are suspecting nausea or delayed. What is the loading dose? 20 mg per kg. Okay, we should be careful when we write. It is 20. Obviously, you wrote it in speed, so it is 20 mg per kg, milligram per kg. And what receptors does it act? 20 mg per kg over 20 minutes. That is 1 mg per kg per minute. That is the time in which, very good. So we have got the answers for the receptors. It is the GABA receptor. So loading dose is 20 mg per kg over at least 20 minutes. That minimum rate should be at least 1 mg per kg per minute. And mechanism of action is, it binds to GABA A receptor subunit, increases the influx of chloride into the neurons. It causes hyperpolarization of the neurons and decreases the excitability. Okay. What is this? Everybody knows. What is this? It's already written. So it's a Bactec culture bottle. That is, so it is rather than blood culture, I would be looking for the answers of Bactec culture bottle, because culture bottle can be conventional culture bottle. It can be. So what is the principle for its usage? How does it detect? How does it give so we all know, we take the sample in this bottle, put 1 ml of sample. You have to put at least 1 ml of sample, and then you put it inside the machine and it will give beep. So next day your microbiology friend will call you that your culture bottle has beeped. That means there is a growth. So how is it? Very good. Dr. Manju has answered that carbon dioxide is released by the bacteria which is growing inside. That carbon dioxide reacts with the fluorescent sensor, and that sensor, when the LED light falls on it, it will give a beep when the fluorescent marker is there. So everybody has told the advantages. It is fast, it is earlier detection. In 24 hours, you would get a. So all the ICUs, I would say, wherever you're practicing or you're going to practice, if you're dealing with sick cases, you must have Bactec bottles. Conventional culture bottles, although they give a result, but by the time they give the result, the baby will already be gone. So for salvaging very sick babies, so first of all is prevention of sepsis. Everybody knows that you should have hand hygiene, but if there is sepsis, if you have to salvage the baby early or change an antibiotic, you must have Bactec bottles. So the blood sample principle, coming to the breast side, as the blood sample is added to the Bactec bottle, bacteria, if present, grows in the culture media. Bacteria metabolism produces CO2. CO2 dissolves, carbonic acid is produced. It decreases the pH. The pH change activates the fluorescent sensor at the base of the bottle. So there is always when you see the Bactec bottle, next time just say the base. There is a sensor which is there in the base of the bottle. You'll see a white thing there in the base of the bottle, white or gray types thing. So the LED excites the fluorescent dye. The increased fluorescence is detected by the photodetector, and the instrument flags bottle as positive. Okay. I hope it is clear. Thank you. So this everybody has told. Let's turn around time. Faster growth of microorganisms. Some of the Bactec bottles, they also have antibiotic resistance. So principle is detection of the microbial growth by measuring the CO2 production. So thank you everyone, and thank you for such an interactive discussion. Thank you, Dr. Kavita, for suggesting that you use the chat box. Thank you. Otherwise it would have been very monotonous.
Thanks, Dr. Dina. Excellent session, actually. Even though we didn't cover most of the equipment, but the type of questions you have asked, I think the fellows